me on cameras? You can hear me? Angelica, can you hear me? Okay. So I just want to start in the usual way. A small but very important change for today's tumor board, live tumor board, is we've expanded the cases from just cervix cancer patients to all of gynecology oncology. And so we're inviting all those who, subsequent to today, after today, present cases, to please expect all of gynecology cases. And indeed, I want to welcome everybody who's attending, and a special thanks to our two presenters this morning. Dr. Georgia Sintra from Barretos in Brazil will present our first and third case, and Dr. Angelica Nogueira from Minas Gerais will present our second case. And I believe Angelica will be presenting an ovarian cancer patient. I'd also like to welcome and thank you to our panelists and from MGH and around the United States. I'd like to emphasize our usual housekeeping rules for first-time attendees. Please keep your microphones on mute, which everybody's doing, thank you. Unless you want to speak, then you can turn it on. But it's important for general environment to keep the microphones off. And just a reminder that today's discussion and the PowerPoint slides are being archived for you to review, or for anybody else in your group who may want to see the tumor board after it is completed. We're also going to take a moment at the end of, a new thing we've introduced is at the end of the tumor board, we're going to ask you to all please take a moment to take a group photograph of everybody in the room with you. Whether you're a viewer or on camera, we'd like you to just stand up and take a selfie of everybody in the room so that we can add that to our photograph collection. So with that in mind, I'd like to please get started. Thank you very much. And we'll call on Dr. Georgia Sintra from Barretos in Brazil to present the first case. If you just wait a moment.
Okay.
Okay, there we are, Georgia.
Okay, thank you again very much for the opportunity. So our first case is about a 17-year-old, a very young lady, a 17-year-old woman. She's nulliparous, and she was referred to us due to a complaint of rapid abdominal enlargement, and she underwent left salpingo-oophorectomy and peritoneal cytology in another institution with a fenestrine incision, and the pathology revealed a sinus endodermal tumor with positive peritoneal cytology. So her first appointment was 3 weeks after that surgery, and on her physical exam she had a PS of 3 due to abdominal pain. She was more than 50% of time in bed, and her BMI was 24, and she had a very large tender solid mass occupying the entire abdomen. Her alpha-fetoprotein was more than 57,000, her LDH 1,180, and CA125 108. The chest and abdominal CT showed no disease outside the abdomen, but had multiple nodular lesions with diffuse distribution in the abdominal pelvic cavity, forming masses, the largest with about 30 centimeters, associated with small ascites and signs of abdominal wall invasion. So here is her CT. You can see she forms conglomerate of those masses, including over the liver capsule. Apparently there was no infiltration of the parenchyma. And next, please. And you can also see she had invasion of the abdominal wall in the previous fenestrine incision. Okay. Next. So we have a diagnosis of endodermal sinus tumor, and she was hospitalized for pain control and nutritional support, but patient remained with a PS of 3, even with that in a hospitalization. Okay, next, please. So we have this case of a very extensive 3C endodermal sinus tumor in a patient with a poor PS. And after review of the literature, we considered here in a hospital a neoadjuvant chemotherapy although some people were reluctant because they don't believe it's important. It helps in germline tumors. And we would like to hear from the experts if you would consider the neoadjuvant chemotherapy or attempt a primary debulking surgery, and what is the role of neoadjuvant chemotherapy in germline tumors. Thank you.
So who wants to start the discussion of this very sad young 17-year-old woman?
Well, can you just clarify the timeline?
Yeah, exactly.
Here, so when did she have the left salpingo oophorectomy? When?
She had it was 3 weeks before her first appointment. So at the time, well, we asked for the surgical description, but we couldn't have it. But the patient said the abdominal wall, the abdominal enlargement was in about 1 month. So it was a very, very rapid abdominal growth. And the patient had a poor PS in the last 2 weeks. She said when she performed the surgery, she was feeling fine. She had only a few very tender abdomen, but she didn't have an abdomen on that side, of that size, and so it grew very, very fast, and her PS fell very, very fast too. From the first, sorry, from the.
Let me just stop you for a second. So she had surgery through a fan and steel incision. So there was there's no way to know what the extent of disease was at the time.
No.
Initially underwent
we
surgery.
couldn't have the surgery description from her home hospital. But from her first appointment to the CTs, it was 2 weeks. So from the first surgery and the CTs, we have an interval of 5 weeks.
5 weeks?
Yes.
Either of you, do you want to just comment? For our education, can you say a bit about this pathology and the alpha-fetoprotein, the beta-HCG, and the germ cell nature with a 17-year-old girl? Can you just tell us a little bit, educate us?
Well, so like non-epithelial germ cell tumors are the most common in younger women. There's different types of germ cell tumors, and unfortunately, they are pretty rare. So the overwhelming experience on chemotherapy that's going to be applicable to this patient is, I don't think that exists regarding your question about neoadjuvant chemotherapy, but these are generally treated surgically. We do offer adjuvant chemotherapy for these patients, and we really have learned from the treatment of testicular cancer in terms of our choice of regimen. So this is not a case where we would give carboplatin and Taxol, as you are agreeing. We generally will use a testicular regimen. I know of no data about, quote, neoadjuvant therapy. I'm not sure if that term actually qualifies, given her original surgery was done 5 weeks before presenting with massive disease progression in the abdomen. One wonders if she already had stage 3 disease at the time of presentation. And the surgery, you'll never know because it was a fan and steel, so she was not explored.
Is this like a non-seminoma in boys?
Well, it's the only extrapolations we make is therapeutically. Prognostically, it's not entirely clear. We don't have an international germ cell classification as they do in testicular cancer, for example.
Because this is a bit more open and shut with just two subtypes, seminoma and non-seminoma.
So the counterpart for seminomas, these germinomas.
Okay.
And they usually have the best prognosis of the germ cell tumors. They respond better, a little bit better to chemotherapy, definitely more to radiation.
And they just elaborate beta-HCG like male seminoma? Or do they elaborate alpha-fetoprotein as well?
So these germinomas is actually, it's not HCG, it's actually LDH, the one that is usually elevated.
Okay, all right.
Yeah. Usually, but I think I completely agree with Don. I mean, I think to me it's, we're looking at the CAT scan, and it just, to me, I've never seen something like that grows so fast in 5 weeks. It's definitely worrisome. Again, like Don said, I don't think there's any data at all about neoadjuvant chemotherapy in germ cell tumors. The good thing about germ cell tumors is that they are, in general, very chemosensitive. So, that's the only good thing that goes in her favor. I think
Would you resect?
I would favor doing surgery first. Yeah.
So can I ask the big question up front? Is she going to be treated with curative intention at 17 years of age or not?
Well, what's interesting is it's confined to the abdomen.
Yeah.
Yes, there's some disease that's extending into the abdominal wall. So technically speaking, it's outside, but there's nothing in her liver. Is that a lesion in the liver? Was that read out as a lesion in the liver? This thing.
Yeah. This thing, yeah.
From the discussion with the radiologist, it said it surrounded the liver, was kind of also compressing the liver, but not infiltrating the liver.
So there's no liver. So I mean, I would say yes.
Curative intent.
Yeah.
And so can we ask Anuja perhaps, is there any role for preoperative radiation, debulking radiation? Is the strategy at debulking surgery, or what is it exactly?
Yeah. You'll try. There is not as much data for germ cell tumors as there is for epithelial ovarian cancer in terms of debulking. In ovarian cancer, we know that if we left no residual disease, those patients have better prognosis.
Right.
There is some retrospective data in patients with advanced stage germ cell tumors that you cannot see the same trend, that if you have unoptimal debulking, you have better prognosis. You can argue that that might be selection bias as well. Again, I think this case is, from what we can see in the pictures, is so unusual that you'll have to tailor to this specific patient. In my opinion, I will probably consider surgery first, try to debulk as much of the tumor as I could, and then go ahead and do chemotherapy.
Adjuvant chemotherapy. So just to be clear, because again I'm being educated here, the strategy up front would be curative intention, not palliative, and start with surgery, not radiation, not neoadjuvant chemo. Start with debulking surgery, like a gross ovarian cancer, and then follow with adjuvant chemotherapy. Of what would you pick?
Well, I mean, the treatment of choice would be bleomycin, etoposide, cisplatin, BEP. I'm going to sort of argue with Alejandro here. I mean, I think if there is concern, given her performance status being so poor, nutritional status being so poor, that her morbidity from a primary surgery is found to be a huge problem, I don't see any reason that you can't start with chemotherapy. Quite frankly, you could, 80% of these tumors, non-disc germinomas, should respond to platinum. I would not treat her solely with platinum. I probably would do 2 cycles of BEP, re-image. If you see a window for surgery, either her performance status improves, nutrition status improves, and the CT scan improves, I would absolutely take her back as early as possible for a curative surgery.
So not really a true neoadjuvant course of therapy, but an attempt to improve her treatment, her performance status, and her tumor bulk, right?
Yeah. I mean, but the problem again, just thinking out loud, if you use bleomycin, it's going to make anesthesia
that's what I was
and
thinking.
intubation incredibly complicated. So you might just use EP if you're planning to take her back to surgery, because again, bleomycin is associated with pulmonary toxicity, and high flow O2 or an intubated state is a high risk factor for pulmonary fibrosis.
So if I go back to my very early career when I used to do a lot of male germ cell tumors, is the regimen what's it called, VIP, ifosfamide and platinum and vinblastine?
But we switched that to bleomycin, etoposide, and cisplatin, and there is some data that maybe some people are actually moving towards just doing etoposide and cisplatin and dropping the bleomycin. And we've done it here. I don't think the data that we have, the clear data is the through regimen, but again, more and more people are moving away from taking away the bleomycin.
But what would you do? So right now, because of her performance status and the need to so-called chemo debulk her before she goes to definitive surgery, would you avoid the bleomycin?
I think I would. I actually would just give her EP.
So we down to EP given first because of her performance status, not as true neoadjuvant chemotherapy, but as a way to improve her performance status and maybe chemo debulk her a little bit. Then definitive surgery, omitting bleomycin in the first 2 cycles, just give EP because bleomycin will indeed cause problems with anesthesia. And then go on to debulking surgery. And would you go back to BEP at that point?
I think I would. I think I would try BEP at that point. If she's 6 weeks out, I don't think there would be a contraindication to it.
Tom, join us.
As long as she responds to that, I think she responds to this chemotherapy.
Yeah.
They're very chemosensitive.
Okay. So that's we've just been joined by another faculty member, and we might get Dr. Tom Randall's opinion here, if you don't mind. We'll just pause a minute and let him catch up with the case. A 17-year-old with a ragingly high alpha-fetoprotein and a gigantically occupied abdomen, but without liver infiltration, without distant metastases elsewhere. So the consensus so far has been she's got a very poor performance status from this.
Right.
And it's very rapidly growing. So the consensus has been not classic neoadjuvant therapy, but start with chemotherapy anyway because of her performance status. Omit bleomycin.
Just omit the bleo.
So far, I haven't heard anybody, I'm waiting to ask Anuja, but I haven't heard anybody, Tom, say that any form of radiation here is part of the treatment.
No radiation. I don't think there's a role in radiation.
Okay.
No, I completely agree. I think I apologize, colleagues, for being late. I completely agree with this. I think that this is one of several cases where it's too bad we don't have Dr. Schmeller here this morning, because I think it's something where we should maybe be thinking about at least a registry. If not, this is going to be too uncommon a tumor for clinical trials, but I think in the setting of, due to the heterogeneity of access in Latin America, there are going to be more cases like this than we see in North America, and therefore a registry of how best to treat or looking at the outcomes of these patients with very advanced germ cell malignancies of the ovary would be helpful, and would bring us different information than we would get from North American, more homogeneous registries. I absolutely agree with neoadjuvant because, of course, we don't. There's very little evidence, but we have no choice, and so it's the only prudent thing to do.
I think so far we haven't called it classic, a cycle of neoadjuvant. We just more or less want to give neoadjuvant because of her performance status to help it improve. Before we thought originally that the primary approach would be debulking surgery, but then Don raised the point that her performance status is so poor and it's such a large operation, it might be unwise to do that with an ECOG of 3. So give some chemo to taunt the tumor down.
I think you'd use a really good phrase. It's chemo reducing. We're trying to just reduce the volume.
With chemo.
But as opposed to, like, say, neoadjuvant, where we give all of it up front, or 3, I would just say 2 cycles. Try to get to the best window possible. Take her back, operate, and then complete.
So
I somewhat disagree in that germ cell tumors of the ovary tend to be highly chemosensitive.
Correct.
I think if this patient had a better performance status, what I would recommend is either a laparoscopy or a mini laparotomy, big enough to get the experienced surgeon's hand in the abdomen to assess the resectability of this patient. I think that given the chemosensitivity of these lesions, we would want to avoid a highly, highly morbid surgery. And my impression, not a radiologist, but as a surgical oncologist looking at those CT images, is that at the moment, even with an ECOG of 0, this would be an extremely morbid surgery.
So how about the compromise, not planning a full, say, 6 cycles or whatever of neoadjuvant chemo up front as a first thought in one's head, but more a few courses to see how she reduces. If it melts away the way testis germ cell tumors do under platinum, then keep going until you get to the minimum volume and to avoid the morbidity of a big debulking surgery, as Tom suggests.
No, I agree. I mean, I think my assumption is that after 2 cycles, she will have very minimal disease. I think this should actually melt quite well.
Can I ask you the testis question analogy again? With non-seminomas of the testis, we used to be afraid of residual masses eventually recurring as teratomas or something else down the road. Does that happen in this disease as well?
Yes, it can.
Okay.
We just had a case.
We just had a case on Monday about that.
Okay.
Yeah.
So the attempt here should be to remove all evidence of disease and render the abdomen no evidence of disease.
Yeah.
Okay.
Yeah.
All right, thank you. Thank you very much for that interesting case. Angelica, would you like to present the case from Minas Gerais, please, from Brazil? And welcome to the tumor board. Thank you.
Yes, thank you. Thank you for the opportunity to present today and have your opinion. So the patient is 33 years old. She has no children. She was previously healthy, HIV negative, non-smoker. The patient started presenting pelvic pain in the beginning of 2015, and her CA 125 was 423. Next, please. The patient has a very important familial cancer history. Her father had colon cancer when he was 39 years old, and she had two brothers who had colon cancer, and both of them were younger than 40 years old when they were diagnosed. And last year, the patient, due to this important familial cancer history, she did colonoscopy, abdominal and transvaginal ultrasound, and they were normal. And the patient had a CA 125, which was also normal last year, and she had pap smears in the last 2 years, and they were normal. Next. So the patient did a thoracic CT, which was normal, and this was and she had a pelvic ultrasound and CT, which showed bilateral masses in the ovaries and in annexing. Next. The patient also had an MRI that showed the suspect is external iliac lymph nodes, and the mass did not have cleavage plan with psoas and piriform muscles, and did not have cleavage plan with iliac vasculature, and there was also a cystic mass 3.9 centimeters close to the uterine fundus, and in this MRI the ovaries were not individualized. Next. So the patient had a biopsy, and the iliac lymph nodes and the pelvic mass showed adenocarcinoma grades 2, and the right ovarian capsule was biopsied. It was negative for cancer. Next. So the patient was referred to the clinical oncology department. At that moment, her ECOG PS was 4. At that moment, she had bilateral venous and arterial thrombosis, and she needed vena cava filter, fibrinolysis, and bilateral stents. And from that moment to now, she's on warfarin therapy. And we asked the second opinion for the pathology. Next. Next. These are the images for the pathology review and for the immunohistochemistry. Next. This is the panel, and the patient was ER positive, PR negative, and she had MLH1 positive and MSH2 and 6 negative. Next. So this is the final report, endometrioid adenocarcinoma with focal clear cell carcinoma and squamous metaplasia. And again, she was ER positive, MSH2 and MSH6 negative, and it was a high-grade tumor in the final report review. Next. So the local team considered her unresectable at that moment because she didn't there was no cleavage plane with the muscles and with the veins, and at that moment she was PS4, and we started chemotherapy. We started carboplatin combined to paclitaxel, conventional dose, and she had 6 cycles of chemotherapy. Next. After 6 cycles of chemotherapy, the patient is now PS2, she has asthenia, her CA 125 is 8, And now the pelvic MRI shows iliac lymph node, the biggest 1.6 centimeter, and she has a suspected lymphocyte close to iliac veins, and no more disease in other places. Next. So we would like to hear your opinion about the optimal management of this patient at this point. If you would, what do you think about surgery, radiotherapy, which kind of radiotherapy, if you consider that cisplatin should be combined to radiotherapy, and if you have any special considerations for Lynch syndrome patients with endometrial cancer. Thank you.
So sorry, Angelica, I think myself particularly, but maybe people online need some education on this case because this sounds like a weirdoma to me.
Yeah.
So perhaps somebody among our panel could just give us a few background comments about this pathology and presentation, if you don't mind.
So I'm just trying to back up just for, so pretty much she presented with an elevated CA125, and you did some imaging, and she had bilateral masses in the ovaries, and also had an enlarged lymph node, and you guys biopsied the lymph node, correct?
Yes.
Did you also?
Yes, she came from another hospital with these biopsies. It was done in another hospital.
Got it. And also
we just did the review here.
Got it. And also a biopsy of the ovary. Or
They biopsied the mass of the
right. Yeah. Okay. And then, so can you just why was her performance status of 4? I mean, was she?
Yes, at that time the patient had bilateral thrombosis, and venous and arterial thrombosis,
Okay.
and I think that was the main problem, and she had to go to surgery to put the stents, and she was swollen, and that's the main reason that she was so debilitated at that time.
Okay. I can start, Marcella,
yeah,
can jump in.
Ahead.
So it sounds that on pathology she has a clear cell carcinoma of the uterus, correct?
No, she has adenocarcinoma, but focal clear cell carcinoma. But mainly it was adenocarcinoma grade 3 and endometrial.
Okay.
And
is it on the ovary or is it on the endometrium?
It sounds like it's from the
Okay.
on the lymph node.
Okay.
The ovaries were.
Is the primary from the uterine corpus or from the ovary? Because I'm not clear.
Yeah.
Where's
Yes.
the primary tumor?
Yes, at the end we concluded that it was from the uterus due to her history, and because of the review, the pathologic review, it was endometrial carcinoma.
And
And I think that it's
did she have any endometriosis? Because I mean, it just makes you feel more. This maybe more. Is it an endometriosis associated carcinoma?
Oh, yes, she doesn't have a biopsy of the uterus. She just have the biopsy of the lymph node and the ovaries. And the ovaries were negative, but just the capsule.
Okay.
But she has a family history, and she has she's MLH1 positive. She's PMS2 positive too, which kind of muddies the picture.
I was gonna say, I think she needs.
I don't understand that, but it's at least based on the MLH1 positive and the histology and the family history, it seems like this is a Lynch-associated malignancy, but which is very advanced and could be either ovarian, right? So she has what? She has a 10 to 20% or even 30% chance of uterine and
About
like 6 to 10% chance of
12%
ovarian.
ovary, yeah. It's just that if you look at the largest paper, actually, I think out there is one that Kathleen Schmeller wrote from MD Anderson in the New England Journal of Medicine, and most of the patients with the Lynch 2 syndrome presenting with endometrial cancer, they tend to be low-grade endometrial tumors, but I guess it's more of an academic.
Again, I think that this may be this patient presented to an outside facility. It may be another manifestation of variable access in Latin America. That maybe this is what somebody looks like when they have Lynch syndrome and nobody screened them, and they only present Well, she was screened.
She was screened.
She was screened.
So
She had-
rapidly.
Yes, she was screening. She has done screening at the end of the year.
You've got the doctors here all disagreeing and scrapping, which is great.
Well, I told the tail, but the tail doesn't hold up.
Well, I
I
think
like
What is your uncertainty about the markers or something? You made a point that she had I didn't understand.
Well, she has two DNA repair gene mutation associated markers positive. And so that would be strange to have two different ones
Okay.
positive. I don't, it certainly makes sense to have one positive in the setting of this family history.
So what can be done for this poor patient of 33?
so the problem is now I think there's two dilemmas. A, there's no certainty of what the diagnosis is, and B, she's already received 6 cycles of chemotherapy, which sounds like a pretty close radiologic and serologic response to her CA-125. So to use Paul's question, I guess, at this time, do we think treatment is curative or not? And I'm of the feeling that you can't cure gynecologic tumor with medical therapy alone.
Yep.
So if you want to try to cure her, then I think it behooves you to go ahead with surgery with intent of staging her and debulking whatever's left. And then if we do believe it's radiation, if we do believe it's endometrial, then I would ask Anuja to comment on the role of radiation at the end of surgery.
Yeah, because, I agree with Don first. I mean, I would definitely offer this patient surgery. I will do a complete staging procedure, including pelvic and parotid lymph node dissection, just as assess for the spread of disease, and I think that will help the radiation oncologist to map the fields a little bit better.
So this is Anuja. So I totally agree. I think you should do surgery, and if it's limited to the nodes and the uterus and the ovaries, I would radiate.
How would you radiate her? Considering that we are not sure if it's ovarian or uterus, what would you prefer? Just radiotherapy or brachytherapy, just like endometrial cancer?
So I think it depends on what you find during surgery.
Okay.
But I would do external beam on her. And with the clear cell features, those tend to be a little bit more chemo resistant. So again, I think radiation would be very beneficial.
I would agree.
And it's interesting that she had clear cell in the fact that she had a DVT. So clear cells is usually associated with like a more thrombogenic profile.
Yeah.
So it just goes like along this whatever the story.
So we say this patient, this looks bleak, and you almost feel like this is a palliative care situation, to address your question, Paul. But in a young woman, this is a 3C something, either ovary or endometrial. If it's a 3C endometrial and she can have surgery and radiotherapy, yeah, so she has presumably has a 3C2 if she's got para-aortics, right?
So you would attend,
but she still has some chance. She has a very significant chance of salvage with aggressive surgery, chemo, and radiotherapy.
So you're attempting what used to be in the old days called heroic surgery.
Well, no. I mean, it sounds like she's had a very nice radiographic response to the treatment given to her. I'm hoping, you do a staging procedure. I'm hoping it wouldn't be like a heroic mess where she'd have a colostomy. And you're thinking of all this. She hasn't been radiated, so she's not looking at a risk of exoneration based on what we know.
And just to be sure, you and Anuja in agreement about the radiation type external beam? No.
Yes, absolutely.
Okay.
Absolutely, because this is very advanced disease, and so brachytherapy alone would not be appropriate for this patient. As Anuja says, this is, and ideally, if it's available somewhere, IMRT, because she's going to need treatment of positive nodal chains. She's already got at least one positive node, and it looks like from the pre-chemotherapy imaging, like she probably has multiple positive lymph nodes.
Just one more question. Just one more question. If it's from the uterus, if we have more information during the surgery, now GOG 258 is checking cisplatin combined to radiotherapy in endometrial cancer. Would you consider it or too much? Because she was quite chemosensitive.
Go ahead, Anuja. Why don't you answer?
Go either way.
Yeah.
Say it again, please.
Depends on how much bone reserve she has.
Could you say it again, please, Anuja?
So, you could go either way. We tend to try to give weekly cisplatin with the radiation, but she's already had 6 courses. So it depends on how much bone marrow reserve she has, and that you're doing extended field.
Right.
Okay.
I still think, I agree with Tom, this woman is 39, so I think this is where you kind of go broke and you try to salvage her, and I think you still check off the intent for cure. I do think it's interesting that she has both cell types, endometrial and clear cell, that tend to be associated with endometriosis. And I don't want to belabor the point, but just to reflect on the fact that if that's the case, if this is a cancer that arose from endometriosis, her prognosis is actually better. Correcting for stage and age. They tend to present as younger patients, so her age would kind of go along with that. And we did Alejandro actually, with one of our residents, looked at our data or our experience at Mass General and did a case control study of these patients compared to the ones that had zero histology of the ovary not associated with endometriosis, and they do better. So I think that I would, agree with my colleagues, and I think offering her surgery, staging the tumor, and then and if she's a candidate, offering her radiation therapy, I think would be appropriate.
With a little bit of cisplatin.
Well, I don't know. I'm not sold yet. I think the data that from GOG and also from Portec, which shows you can they're looking at chemo rads as well there. This is not that patient. I think Anuja's point is very valid. She got 6 cycles of carboplatin and Taxol already. Mm-hmm. I think trying to give chemo rads after 6 cycles of carbotaxol will be very challenging. And at this point, I'm not sure if it's worthwhile. But
okay. What do you think about that, Tom?
I think like the previous case, we're all saying the same thing. I do think if it looked like she could tolerate it, I would want to give her as much therapy as we could in this situation, because she's in a bad way, but she has a chance of cure.
So go for broke, Angelica.
But as Don says, you don't want to lose her to your therapy.
Don't throw the baby out with the bathwater.
Right.
Yeah, exactly. If we kill her with therapy, then her survival is short as possible. Her survival is 0.
Well, thank you very much. That was a great case. Thank you.
Case, yeah.
And back to Georgia. Georgia, from Barretos, you come up with the third case, please, if you don't mind. Your second case of the day. So please go ahead. I'm just looking at the list. Can she hear us?
She's not online right now.
Can somebody else? Can somebody else present this case? Angelica, we seem to have lost. Georgia, so I wonder if you'd be kind enough to just present the third case and we show the slides on the screen. Thank you. Okay, go ahead, please.
Oh, wait. She's back.
She's back.
Hello?
It's okay, Jennifer.
Okay, can you hear me? Sorry again for the
problem. We just came to your case, so we can begin presenting that.
Okay. Okay, sorry. Our second case is a 36-year-old woman. She has 2 previous pregnancies, and her complaint is a metrorrhea for the past 7 months. Okay, next, please. On her physical exam at her first appointment, she had a PS of 1, a BMI of 29, and an infiltrative cervical lesion measuring more than 4 centimeters with fornix and bilateral parametric infiltration. and the cervical biopsy was a squamous cell carcinoma. The CT of the upper abdomen and thorax had no evidence of disease. And on the pelvic MRI, there was a 5.4 by 4.5 centimeter lesion on the cervix with initial parametrial infiltration, but also left common external iliac lymphadenopathy measuring up to 4.2 centimeters. Next. So here's the image of the bulky tumor on the cervix. Okay, next. And here's the image of the common iliac node. It's very large, and the largest diameter was 4.2 centimeters. And you can also see that it has a very necrotic core. Next. At our institution, we have no IMRT available, so our radiation oncologists warned us that our external beam RT could not eliminate such bulky common iliac node. So we offer the patient a laparoscopic debulking lymphadenectomy plus a systematic parotid lymphadenectomy followed by tailored chemoradiation. Okay, next. So she underwent the procedure uneventful. Jessica, can you play the video, please? We did a short edition of the video. So here we always do a transperitoneal approach, and here you can see the bulky node even.
Sorry, let me try to open that again.
Just 1 second. We've never done this before.
Okay.
Okay.
That's a great idea.
Okay.
So you can see the bulky node even prior to the peritoneal incision. And here's after the peritoneal incision. It was adhered to the ureter, but it was not a very straight, only with blunt dissection we could remove it from the ureter. But it had a very big extent to the pelvic. So it started at the pelvic and grew up from the cranial direction. So we also had to remove the total of the lymph node without rupturing the capsule, some of the fibers of the psoas. We were very concerned because of that necrotic core that we could rupture that node. And then we went to the pelvic approach, where we could remove the node entirely, thankfully. And we also we put in an endo bag we perform here for financial reasons, and that's the final view of the parotid dissection. And we use abdominal wall protection. We always try to respect the oncological procedures and remove the umbilicus. So it was an uneventful procedure by total laparoscopy, so the patient recovered really fast.
That was beautiful.
Thank you. And the pathological report revealed 6 out of 13 pelvic nodes. We actually only tried to remove the bulky nodes, but the pathologist even found more nodes. And that common iliac positive node, it measured in the largest diameter 4.7 centimeters, and thankfully with no extracapsular spread. And also 1 out of 18 parotid positive node. Okay, next please. She started chemoradiation with extended field 19 days after the surgery. She's now on the 8th month of follow-up with no evidence of disease. Okay, next. So here we have the image of the CT prior to the surgery and the CT after the surgery for the radiation planning. Okay, next please. And what we wanted to ask the experts is, what is the role of pretreatment lymph node debulking in cervical cancer? If IMRT could eliminate such bulky node, and we wondered also if SBRT could be another option of treatment, even an upfront treatment, or it would be left if the patient didn't respond to the primary treatment. Thank you.
Thanks very much. Who's going to go first? Anuja. Anuja, you've been picked on.
So I actually agree with their management. Now, we probably would have started with radiation therapy MRT, and we've had great success. I'm a little bit worried because it was necrotic, and those sometimes don't respond as well to radiation therapy. I don't think SBRT has a role as with definitive treatment, but could be used if she recurred in that area. But I agree with your management. I think you guys did a great job.
So, further comments?
Well, it's an absolutely beautiful surgery, and we've talked about this approach a little bit before, that I think that with minimally invasive techniques, these become very tantalizing. I just want to say again, I think it's very important to collect these data and see what the actual outcomes are. I think that in the states, when this has been looked at, the debulking of nodes before definitive chemoradiotherapy, the results have been less than inspiring. And so, but I think that's, I think that since those studies have been published, in Latin America, you may be looking at a younger, healthier group of patients because there's more prevalent cervical cancer. And I think that the minimally invasive surgery and the effect of the chemoradiotherapy advance all the time. And so I think it's worth looking at, even though the available evidence to date has not been encouraging. But I think in a patient, again, this is a patient where in somebody this young, it's worth, particularly when you can do it with such low morbidity, it's worth a try.
All the old data is pre-minimum invasive surgery. So we need to know what the results are with this new type of surgery.
I agree. I also think that, no disrespect to our forebears, but I think that as Georgia beautifully demonstrated, there are some really nice refinements in meticulous anti-cancer surgical techniques that you demonstrated that really probably make a difference with these kind of things. That, and in the old days, people would have done an open retroperitoneal dissection for this. There would have been a lot of blunt dissection around the tumor. There would have been a lot more morbidity and, for example, hemorrhage, risk of infection, and probably a lot more microscopic tumor spillage, even if the node appeared to come out intact. Whereas this was done with a just really beautiful sort of no-touch technique, microscopic, meticulous approach to the surgical planes, and then putting it in the bag and protecting the abdominal wall. So that this potentially could be a different thing, as you say, Anuja, than the old studies. But we need to collect the data and see.
Anuja, would she have been a candidate for the Outback trial?
No, because she has periodic nodes that are positive.
Okay, so the periodic nodes would have made her ineligible. Okay.
Correct.
Yeah, most of the trials exclude patients with positive periodic lymph nodes.
Yeah. Okay.
So there's like limited.
Marcela, what do you think from a surgeon's point of view?
I agree with Tom's comments. I think the data that I know, some of it was written by Barbara Goff, and this was extraperitoneal access to the nodes, and the morbidity was high, especially because they all had radiation. It was pretty easy to violate the peritoneum, so they were labeled as extraperitoneal, but you actually were in the peritoneum. Big like like hockey stick sort of incision. So I think in the setting of what we can do today with minimally invasive technology, especially where if you have resources that are limited with regards to what you can do with radiation therapy, I think this is the right approach. But I think it's important to collect the data.
So I just want to ask you guys a question. In the breast cancer field, we have set up a global tumor base for patients less than 40 because they fall under the strict definition of rare cancers. Mm-hmm. Breast cancer under 40 is considered a rare cancer. Mm-hmm. And so we have a specific registry which we're collecting lots of cases. And you've mentioned twice today, Tom, about a registry for South America, which I agree with you. They see far more cases than we do. That would be something easy for us to set up in collaboration with all of you. Is that something we should try to do? Is that a project that you'd be interested in?
Can I say something?
Yeah.
So the GCIG has a registry for rare tumors. And actually anybody can put patients into that registry. So I do wonder if they don't have one for the endometrial sinus tumor. But that is actually a great group to try to do big registries on.
Right.
So that's rare tumors like clear cell. It's based on histological rare, right?
Correct.
Yeah.
Yeah, and I think that's very important, Anuja. But I'm also talking about, and I think Kathleen Kathleen talked about this idea using REDCap for this last winter at Barretos. That the idea of collecting these cancers that are more common in Latin America, but that could inform the international experience, because there's, for example, an aggressive cervical cancer like this is something that's less common in East Asia and in North America and Western Europe, and there's not the technology in South Asia and Sub-Saharan Africa to understand what the results for this are. So Latin America is in a unique position to educate the rest of the world about what the best management of these patients is.
It sounds complementary to what GCIG is actually trying to accomplish, though.
And maybe we just need to talk to the people at GCIG to have them start something like that.
But REDCap is actually an excellent idea. I know they're not doing cervix, so they are doing the rare tumor types. So we could look into doing REDCap for specifically cases from Latin America and Africa.
We've used REDCap in the past, but we've moved away from it. We've got a better system now. So we could do it.
I mean, I think if we did something with our colleagues in South America, we'd have to sort of define what the registry, what we were actually going to collect. The most obvious thing that I can think of is the cervical cancer experience in Latin America. I think is very unique, and I think that might be worthwhile. But the other is actually what you're doing in breast. Collecting the experience of young women with a gynecological malignancy is actually quite an interesting thing. We presented several cases of women who are pregnant at the time of their diagnosis, and there's very little data compared to breast on gynecologic cancers in pregnancy, for example.
I think that one thing we've talked about, Anuja, you remember with Renee and with Kathleen, and with Marcella as well, is that in Latin America, there's more of this prevalent cervical cancer, and so it's an opportunity to see whether more modern advanced surgery makes a difference in ways that 20th century surgery for cervical cancer didn't. There are knowledge gaps where we're never going to be able to learn enough about surgery for cervical cancer in North America or Western Europe at this point. And so if we're going to find that surgery and more advanced radiotherapy and different chemotherapy, if we're going to find differences in that, it probably needs to be in Latin America. And so I think that some kind of registry of these more advanced cervical cancer patients with unusual presentations that fall outside of things like Outback would be very valuable.
Well, thank you very, very, very much. Have we answered all the questions from the presenters?
Seems like she has something.
Go ahead, Angelica. No?
Oh, no, nothing. Just
if anybody else. You want to ask a question from Barretos?
Yes, please. Very last question, sorry, for the first case to Dr. Dunn. Do you think there's concern about that first patient about acute tumor lysis syndrome due to the chemo responsive, being very chemo responsive. If we if we should like do any management before starting chemo to avoid it.
Right, we usually talk about a tumor lysis with the hematologic malignancies, but I think what stands out in this case is she has a very extensive tumor burden. So I don't think it would be unreasonable to watch her very closely, with surveillance labs every 4 to 6 hours, make sure her renal function's fine. Compared to, say, a leukemia, though, I think the risk of tumor lysis is probably lower, but I think it's a very good point.
Okay, thank you. Thank you very much.
So in closing, could I just ask you, please, it'll take less than a minute, just if you stand up and take a picture of your room for us, a photograph with your iPhone, somebody, and just send it to Jessica afterwards. We'd be grateful. Thank you very much. And thank you for the tumor ward today. Thank you.
Thank you.
Thank you.
Thank you.
Boy,